All right, just for maybe a little bit of context, last year for this, we had done some post-summit surveys, and many of the attendees had asked for either real use cases or case studies or real-world examples, even though I think we've heard a lot of really good real-world examples so far, this morning. So that was the reason we planned this session. So we're going to be talking through an actual use case with the state of Georgia. So we're so honored that they're here with us today. We're going to be talking about a dental provider and providers as a use case. That's not one that we see super often, mainly because they kind of fly under the radar a little bit. And also you need good analytics and good subject matter experts to look at, dental data and dental claims. So with that, I'm going to let the panel introduce themselves, and I'll start with you, Johnny.
So good morning, and thanks, Rena, for this great opportunity to speak, along with Codoxo Fraud Scope. I'm Johnny Brooks, Director of Program Integrity for the Georgia Department of Community Health. I started with the department in 2019 as an assistant director, eventually promoted to Director of Program Integrity in 2022. Prior to joining the department, I spent 13 years at the Medicaid Fraud Control Unit, investigating Medicaid fraud. I participated in search warrants, on sites, testified at trial, participated in offered grand jury testimony, both federal and state, worked cases with federal and state investigators, GBI agents, HHS, OIG agents, FBI, you name it. Walked out of there with several guilty pleas during my tenure of 13 years. And then prior to joining the Medicaid Fraud Control Unit, I retired from the military after 20 years of service. So thanks, and it's excited to be here today to speak to you.
All right. And I am Derik Ciccarelli. I'm the Director of Fraud Scope Operations. My background goes 30 plus years in fraud investigations. The first 20 years of my career were spent as a private investigator focusing on insurance defense in the property and casualty space. So I worked fraud investigations, whether it be auto accidents, workers' comp, did some corporate work, testified all state court, all state levels, federal levels, prosecuted some people for fraud. Then moved into like operations and management of surveillance and investigative teams throughout the Southeast. Ended that in like 2011, and then migrated to healthcare fraud in 2012 with a little known company called EDI Watch, who then ended up getting picked up by LexisNexis. Worked in their special investigations unit for 8 years, and helped monitor and service dozens of plans through the LexisNexis products. Identified a lot of fraud, waste, and abuse for our partners there. And then just before the pandemic started, as LexisNexis was kind of migrating away from the commercial space, Mashir caught up with me on LinkedIn, and he's savvy. And we talked for a little bit, and I interviewed with Fraud Scope at that time. I forget which employee number I was, maybe 16. We were still in the incubator space, and joined there, and it's been just a great ride ever since. I'm a customer success member number one, and I've been really entrenched with all of our partners, especially during our state of Georgia pilot several years ago, which kind of kicked us off where we are today.
That's why we're here today.
That's right. Yeah. So.
Well, that's funny because Mashir found me on LinkedIn too. So
What was it? Was it on?
it's an AI pattern or something he did. I don't know.
Was it on a Sunday? Because it was always on a Sunday for me. I don't know. Anyway.
All right. So we're going to start with Johnny. The question we have for you is, before you did your AI journey and implementation, how did you approach the challenges of balancing fraud detection and payment accuracy? Can you tell us what was working well, maybe what was not working well, or what limitations you had?
I think what we can do is start first with what was not working well. And I'll say that before implementing the artificial intelligence platform, we rely primarily on hotline calls, which is not a very effective mechanism to attack fraud, waste, and abuse. At the end of the day, the mission of DCHOIG is to detect fraud, waste, and abuse. So when I come from the arena of the Medicaid Fraud Control Unit and walk into the department, and we're kind of relying heavily on hotline calls, it was a little surprising for me, but nevertheless, we're excited to be here today to talk about the use of AI and how it could benefit the agency today. We also relied on referrals from other agencies, whether it be federal, state, or internal departments within Department of Community Health. And then we finally utilized quarterly surveillance utilization review reports. So for folks that are not familiar with SURS, it's kind of a federal mandate that on a quarterly basis, we, the staff of DCHOIG, specifically Program Integrity, meet on a quarterly basis to review statistical or standard deviation statistical samples of providers that may have been flagged in the system for aberrant billing trends. The issue with SURS is that it doesn't give you the claims data that's actually associated with the standard deviation score. Codoxo does. So that's the beautiful thing about Codoxo, is that it not only ranks and scores the providers based on a risk score that's been assigned, it also identifies the aberrant billing trends. And oh, by the way, it identifies the claims that are associated with those aberrant billing trends. So folks, that's huge. I wish I could have had this type of tool when I was at Mafuku. I would have walked out of here with a lot more indictments, to be honest. But nevertheless, we, DCHOIG Program Integrity, as a result of having to rely on hotline calls or SURS data analysis, we have to take that additional step to actually review the raw claims data and then determine what the aberrant billing trends are. So in that, taking that approach, we've heard the term timeliness being reiterated time and time again today. The quicker you move on a case, specifically the claims data analysis piece, the better the outcome of the case. So I can remember when I joined the department back in February 2019, my boss walked in, my predecessor says, "Hey, the commissioner's got this letter, provider file of self-disclosure, but we think something fishy is going on. Take a look at it." Well, it took me about 3 to 4 months to take a look at it. By the time I digested the letter, pulled the contracts, pulled the claims, determined what type of provider, review the allegations that were stated in the letter, and then perform those steps of conducting and identifying the aberrant billing trends, probably about 3 to 4 months later, not 3 to 4 weeks later, I was able to present at least a PowerPoint presentation to him that says, "Hey, here's what the next step should be. Here's what the findings are. And I would recommend an immediate referral to the Medicaid Fraud Control Unit." But again, we're talking about 3 weeks compared to now having a system like the AI platform where I can just press a button. Here's your report. I think it's wonderful. I think we're in a great space now. The challenge that I have now is building the team to actually learning how to utilize the system of AI to detect fraud, waste, and abuse, and then encouraging people to work together as a team. We'll get into that a little later.
Awesome to hear, Johnny. So given that you had all of those manual processes, maybe a lack of technology, of everything that you mentioned, could you tell us which one, if there was one, was the top driver of your decision to move to a technology platform?
I think the top driver for me, and again, based on my observation when I joined the department, was the lack of expertise in data analytics. I reached out to my federal comrades over at HHS. "Hey, I desperately need some training here or some courses that I can put my folks into to learn about data analytics," right? The second thing I noticed was we were kind of fragmented, right? You got a staff of clinical support nurses that are charged with doing the medical records review. We got data analysts that are charged with pulling the claims data. The problem is they don't know how to review the claims data to identify the aberrant billing trends that are associated with the allegations. We got to rely on the nurse. So in that spirit, we were kind of fragmented. And at that time, when I joined the department, we really didn't have an investigation unit. We ended up standing up an investigation unit as part of the reorg that Sonia mentioned earlier. Again, is the challenge we had was actually having staff with the expertise to understand, hear the allegations. Can we review the claims data and identify the aberrant billing trends associated with the allegations? What are the additional findings or aberrant billing trends that you identified? And then determining whether or not a utilization review is warranted. Do we want to do a desk on site, a desk review, or do we want to do an on site visit at the provided location? And again, all the emphasis being driven by the fact that the faster you move, the better the outcome of the investigation.
Thank you, Johnny. So Derik, if you could maybe speak to your perspective on kind of the nuances between fraud prevention and payment accuracy and your experience there. I'm sure they'd love to hear about that.
Sure, thank you. So there's a couple tracks, I guess layers between fraud prevention and payment accuracy. Uh, Obviously, in the highest level, the objective in the fraud prevention side is looking for those fraud cases, those outlier providers, the people that are, you know, either criminal entities or just doing intentional fraudulent claims billing. And then on the payment accuracy side, you're dealing with more waste and abuse policies, coding, and that as that trickles down, as you're looking for that, pointing back to what Johnny was talking about, what are your tools and techniques that you're using? In fraud prevention, a lot of it is, well, both in fraud prevention and payment integrity, using data mining. But in the fraud side, you're looking for suspicious outlier behaviors. Sometimes you're using supervised models. Could be rules-based or deterministic type scenarios. And again, all focusing on these suspicions patterns to find a criminal intent. Whereas in the PI side, it's like, well, we want to find these improperly coded claims, things that are outside our policies. And while some of those instances may lead to a fraud referral, because at times payment integrity can lead in that direction, they are separate tracks. Now, as you get into whether those are separate entities, sometimes you have your plan as a fraud group and a PI group, and we see that quite often. Sometimes there are benefits of that separation, and sometimes there are detractions there. Some of the benefits in both having a fraud-based unit and a PI-focused unit, you're going to have focused expertise. You're going to have some resource allocation, so dedicated staff into that very specific area. You'll also have some clearer accountability. So your PI teams or your fraud teams are very focused and you know what your responsibilities are. But in the fragmented side, something that kind of Johnny spoke with as well, the drawbacks of separation are going to be those missed synergies. So often you see plans that are working on something and the right hand doesn't know what the left foot's doing. And you really have to coordinate well these days to not overstep or overreach or maybe detract from maybe an active fraud case. If a PI team says, hey, we got this PI thing, and Johnny's saying, hold the phone, we've got an active investigation on them. You've got to have that clear communication point. You're going to potentially run into an abrasion or miss out on a great fraud opportunity, potential fraud referral. So that moves into like inconsistent strategies. And then you also have, with that separation, you run into some higher admin costs as well. And then, once you get away from separation, you get into integration, which is key critical, unifying the data, making sure that you understand what your overlaps are, improving your efficiencies as you integrate, and then hopefully improving your outcomes. So again, the communication and collaboration between the teams really helps with that. And in terms of how AI does that for you, in a unified system, all of those data points are held together. Those providers who are cutting across maybe even multiple claim service types, maybe dental and professional or facility and professional, are obviously prescribing information, and any one of those other claim service types. Having all that in one place really gives you a full visibility. So you're not worrying, you're not as lost with what is my PBM doing, or does the facility know what the professional side or the dental side is doing, things like that.
So in essence, you're kind of able to break down the silos of those manual processes that
Absolutely.
Johnny was speaking about.
Mhm.
Awesome. Okay, to you again, Derek. Could you maybe speak about those key detection models that have been most valuable for Georgia?
Sure. Um, so the we'll talk the use case that Johnny's going to talk about was a dental provider, and a lot of what was flagged for that provider, along with other peers, were in the pattern-based side of the house, which is our true outlier detection analysis. Um, Deterministic rules, things that like that, as you would find, payment integrity level. There, some of those are going to exist as well. But the high value, especially in a fraud referral, comes into those pattern-based detections, showing the outlier anomalies. So for this particular provider, who's a dental provider, it was things like high number of patients per day, high number of services per patient, high number of units per patient. I mean, this particular provider hit on pretty much all of those service outliers, along with a lot of other, deterministic type detectors, and then there were some hybrids as well. So when you're thinking about fraud, or you're looking at payment integrity, at times those units per patient, paid per patient, that high density utilization per patient is a really strong signal. And in this case, well, it's very obvious for our dental provider.
Great. So, Johnny, those insights that Derek was mentioning in the detection, can you maybe speak to how your team is adapting to working with that type of analytics versus what you were doing traditionally before? I know it's a little early, but if you could speak to that.
Yeah. So we participated in a pilot essentially during the pandemic, and now we're in our final stages. I think we've gone live late April. So we're kind of in the early stages now of creating some internal business processes now that the AI platform is certainly here to stay. So far, we have identified some providers of concerns. We do Georgia contracts with 3 managed care plans. We have sent out some CMO directed review letters. I sent them out yesterday, Derek.
Okay, all right.
I sent out 3 letters yesterday to our managed care organizations for one provider that actually flagged in the system. Um, and so we do have some concerns. That particular provider was flagged with a risk score of 92, and was flagged for billing excessive members in a day. So we internally have that responsibility to exercise some oversight over our managed care organizations. And as a result, we have sent out CMO direct review letters to alert the CMOs, hey, there's a potential concern here with this provider. Here's what the provider is doing. You can call me if you need the claims data because I have it. But please, within 30 days, conduct a billing risk assessment to determine if a utilization review is necessary. And the MCOs must respond to me within 30 days to advise, hey, Johnny, we're going to open a case or we're not going to open a case. And here's why based on X findings.
Mhm.
Great. And can you speak about now that you have kind of probably more information available, how is your team prioritizing those analytics and what's getting presented to you?
Yeah, so I would say that we're prioritizing cases based on the exposure amount and potential referral to our MFCU. So that again is one of our number one priority goals is detecting fraud, waste, and abuse. Part of that is if we conduct a utilization review of a provider and it results in credible allegations of fraud per CMS guidelines, we're required and mandated to send a fraud referral to our Medicaid fraud control unit for further investigation and potential prosecution. Um, and I also say that we also want to focus on when we're sending those fraud referrals to Mafuku, does the aberrant billing trends align with a clear policy violation, right? So there's one provider, Derek, that I met with the team on that is currently in the system. It appears there may be some issues with this particular provider because there's some exceptions that have been extended in the policy that's not identified within the platform. So those are some things that we kind of some nuances that we have to consider and evaluate on a case by case basis. But certainly, when there are aberrant billing trends and the policy clearly supports, hey, provider A should not have billed claim A, B, or C, then it should result in a fraud referral to Amafuku for potential investigation and prosecution.
All right. Okay. So moving to the actual case study, Johnny, if you could maybe walk us through the actual provider, which you did identify prior to having an AI platform. But if you could maybe walk us through that particular.
Yeah, so one of our MCOs actually sent us a fraud referral a few months back, and the provider was flagged for excessive billing trends for extractions of tooth or bone removal. Procedure codes associated therein are D7210, 7220, 7230, and 7240. This particular provider was exceeding his peers in network. Kind of a similar scheme that would be flagged for this particular provider in the AI platform. The MCO conducted a review of the medical records. The medical records revealed a 90% error rate. Red flag number 1. Red flag 2, 3, 4, and 5. Missing provider signatures on the notes. Missing vital signs on the notes during administration or sedation of sedation. Cloned medical records. No indication of surgical extraction or impacted tooth or bone. Wait a minute, why are you billing these codes?
Yeah.
All right. And then no documentation on services rendered. That's the classic sign of a potential credible allegations of fraud. And so as a result, a fraud referral was sent to our Medicaid fraud control unit. As soon as we decided to, we gained access and was in that process of implementation, Derik got the claims data. He opened up the claims data for Georgia. This provider popped up first on the screen. Hold on a second, Derik, we need to have sidebar conversation.
Yeah.
Provider is a fraud referral for that same provider. So it works. The provider was flagged for this same code, D7240, that was identified by the MCO. So again, as I tell folks all the time, it works.
Yeah.
Maybe just an interesting side note. You mentioned the clone medical records. Some of us were discussing that yesterday, that, some providers, like the bad ones, will maybe start to use AI to create records that look slightly not cloned, right? So they're going to be a step ahead of us in that regard. So I thought that was an interesting discussion. So also maybe something to be aware of. But Derik, if you could maybe expand a little bit on that provider and also how the system kind of validated what had been found and what we were looking at.
Sure. Yeah. Well, as Johnny mentioned, that provider had after their review, they obviously found all these problems. But the way the AI looks at it is taking this provider against its dentistry peers, and he was not a general dentistry. He was not general dentistry. He had a little bit more of a specialty, like endodontics or something like that, I believe. So a little bit more of a specialist. But it's taking all of that utilization against his peers and saying, okay, how many patients per day is this provider seeing, and how all these services and units and teeth per visit, and just really running all those calculations and looking at those percentages and anomalies across the rest of the peers, and in this case, endodontics. And so as it's surfacing all that up, it's bearing that analysis down to the very specific code level. So the D7240, the 7210, all those extraction codes, along with, I think there was some sedation codes that he was billing as well in the D93 series. And it's taking all that, aside from comparison with the peers, and it's saying, here's a problem. They're highly scored. Oh, and by the way, here are all the claims attributed to that particular code in that time period that have these outlier scenarios. So in Johnny's case, where he's dealing with MCOs and fee-for-service, he can then say, give me all that data. Let me get all that. Let me get everything that's related to high service patients or high tooth counts or services per tooth, whatever it may be, and bring that to bear to my partners externally. And whether they do the utilization review or not, at least you've given them everything. You don't have to go back to your data warehouse and go find, say, pull this down. You've got everything instantly. And then on top of that, the scoring itself is giving you a sense of the volume. So it's not just, well, there's a lot of dollars, because there were, and it's not just that there are a lot of claims, because there are. It's dealing with the number of detection models. So you could have someone who has, 2 detectors that are kind of low dollar, and they're going to be scored lower. But when you got someone like this who's hitting on like 13 or 14 different detector models, it's going to drive that score up because they obviously have numerous different aberrant outlier behaviors that are driving that score and driving that claim aggregation. So yes, this provider is at the top of the heap, but he also has a number of peers underneath him who display a very similar pattern, all of which our platform says, here's this guy, then here's this person, here's this person. So you have like a hit list. So if you find someone who meets this, high threshold of detections and scoring, and they have 15 peers that are doing exactly the same thing, well, that's your workload right there. I mean, you can just go to that one and go to the next one and go to the next one and work your way down because those patterns are going to be the same patterns, probably less volume, but still the same outlier behavior.
So on that topic with the additional providers that got identified, Johnny, maybe you can tell us what surprised you the most about that when you saw that.
So there was some other dental providers that Derik and I took a look at in the AI platform, and there was another provider that flagged with a risk score of 92. But in this case, the system actually identified a clear violation of Medicaid policy, and let me explain. The AI platform revealed that there was dental service abuse for procedure code D7910 billed with the extraction procedure of D7140. Georgia Medicaid expressly prohibits the billing of those two codes together. Again, that's a beautiful thing about the system. I didn't have to go dig through the Medicaid policy, even though I verified it. The system had already flagged that these codes should not have been billed together. And sure enough, it's validated in policy, and it's clear. And this is another one, Derik, that was sent to the CMO.
Okay, right. That's
Uh,
now.
Johnny could have called Kelly's policy person.
And there was another issue that was also flagged for that same provider, Derik, and it is included in the CMO director review letter as well. And I think the system in this regard, it identified some PTP edits or improper payments for incorrect combination of codes being billed. So not only did it identify the first two codes as an issue, it identified an additional 6 codes that were this particular provider was billing in combination for a single Medicaid member. So that was also included in the CMO directed letter that was sent to our managed care organizations just yesterday.
So and in those instances, that's really like a payment integrity issue. You're dealing with just a fairly straightforward edit, but with other signals potentially on the fraud referral side that you might get into based on, the volume of other activities and detectors. So, it's in our AI platform, we have different models that address different types of problems. So if it's going to be payment integrity issue, that's great. Or if you want to venture into the fraud side, you've got both. And then there's some hybrids as well that could go either direction depending on, how the claim suss out.
So Derik, were there specific AI detection patterns flagged that you can maybe speak about with those providers?
Well, so aside from one of the things that we did for the state of Georgia, two things actually that we did for the state of Georgia prior to them going live that were coming out of the pilot. We developed the unusual time period detector. So we developed a detector that said, hey, your provider is submitting claims 6 months or more from the data service. So delayed claim submission can be a real problem. We've seen that happen with DME, especially more recently with the catheter schemes. Then we also developed a series of detection models around dental specifically to help identify these instances of anesthesia, other services occurring during crown removals or crown implants, things like that. So there's quite a few of those that got implemented pre-go live. And then the detector models that were flagged for this provider. Again, getting into the high service units. Anybody who's listened to me either as a presentation, as a partner, or even nationally, like NHCA or NAMPI, I think some of the strongest signals you can find in the fraud space is high utilization per patient and the deviation thereof compared to peers. If you've got somebody who is doing 10 times as many units or getting 10 times more paid per patient compared to their peers, that is a super strong signal and should immediately gravitate you right to that provider to see what those claims are and what's driving that traffic. Sometimes it's utilization shift, and sometimes it's becoming a constant. But in Johnny's dental providers, there's a lot of these service units per patient, procedures per day, treatments per tooth, all of which is pushing into that volume metric and that utilization per patient. I view the patient as a credit card. So when I think of the patient ID as a credit card, it is they come in for services and that provider now has access to the credit of that, the dollars associated with that patient. So the more claims they submit, the more services they do, the more money they put on that credit card. And that's probably a different analogy than most people are used to. But if you think about what that Medicaid ID or that Medicare ID does, it is not unlimited, but it has access to a lot of funds. And as those providers dive more and more, as a provider dives more and more into that patient access for dollars, that is where that credit comes in. So I'm looking for people that are attacking the per patient mode, because that is usually where those bigger fraud dollars are showing up in those bigger scenarios. And that's what Johnny's case, services per patient is really diving into.
That's a really great point. So maybe just spend the next few minutes on kind of impact and future state for the state of Georgia. And I know you're kind of early, but wanted to maybe touch base on that. And can you speak to how your team's workflow has changed? You mentioned you had maybe these kind of siloed teams and disparate manual processes going on. Can you maybe speak to any changes you're making?
Yes. So again, I spent 13 years over at the Medicaid Fraud Control Unit, and we work cases utilize a team-based concept. So each team was composed of a prosecutor, investigator, an analyst, an auditor, and a nurse. Now, with Department of Community Health Program Integrity, we have clinical nurses, investigators, and data analysts, but they don't work together as a team. So I have that awesome challenge now of creating or shifting the PI unit to a team-based approach that will consist of a nurse, an analyst, and an investigator. I'm spearheading the first team, right? So I've created the first team. It includes myself, the assistant director for data analytics. My other assistant director, she just left last week, but it includes the clinical support manager and some investigators, right? So I'm showing them the task, how to develop an investigative work plan, how to work together. What's the role of the investigator? What's the role of the data analyst? What's the role of the clinical nurse? And it's always my philosophy, leave the nurse alone, because he or she is going to have that awesome task of doing that line by line chart review, right? So I think Sonia alluded to the ruler, and she forgot about the thumb tabs, though, right? you got to have them thumb tabs to turn them hard copy paper charts.
Yeah.
But at the end of the day, what I'm trying to get folks to learn is everyone in this room can comprehend. If there's a claim bill for 1, 2, 3, 4, 5, is there documentation in the chart for 1, 2, 3, 4, 5? You don't need to be a clinical nurse to do that. So I'm trying to get folks out of their head that, hey, you don't have to be a clinical nurse to do that. You can do that as a data analyst. You can do that as an investigator. But if case hinges on medical necessity, that's what the nurse is for. Right? So I'm trying to get everybody to kind of work together as a team to triage these cases, the cases that we get out of the AI platform, and specifically to treat them as task force cases. So in my Fuku world, we would work task force cases either with FBI agents, HHS-OIG agents, and if necessary, we created our own internal task force to kind of expedite that case, because again, the faster you move, the better the outcome of the investigation. So we're looking forward to continuing to work with the AI platform and Codoxo Fraud Scope to identify those providers for potential referral to Mafuku. But I think probably our most important next step may be to incorporate the pharmacy claims data. Though I think we talked about the fragmentation where the medical side and the PBM side don't communicate. I think one of the speakers alluded to that earlier. So I think, once we get the pharmacy claims data in there, then we can bring those opioid prescribers into play.
Yeah, you have a lot of medications as a treatment in your
Well, as a pharmacist, that is near and dear to my heart. So
Yeah.
I'd love to do that. Okay. So Derik, from your perspective, maybe just speak about technology and how it's been evolving, which we've been talking about throughout the day, and maybe moving any intervention earlier in the payment process.
Well, I'd say I think gentleman from Capital RX piece still here. I think he left already, AJ. One of the key aspects, no matter what system you have, is data health integrity. If you do not spend the time you're never going to have perfect data, by the way, never going to have perfect data, but as close to truth as possible so that you can get truth out of it is critical. And then someone else spoke to institutional knowledge in terms of AI. I think where we're going, where we have Gen AI currently in the platform and are opening that up to our partners, this is where that transfer of SME knowledge and institutional knowledge comes in and lets that technology start to learn and develop and gain from the experience of the people in the institution. It's not a division of knowledge. It's not okay, now the AI knows everything. It's always going to be building that knowledge in. So I think the transfer of knowledge is critical, and to allow your people, your staff and support staff to come in and, query and build and ask more of the Gen AI platform to learn what it's looking for, to learn what it should be trying to find and understand greater and greater about your claims data. And in terms of where that is going to shift for fraud, waste, and abuse and PI, I would like to see, I think it's going to be integration of outside information that's actually true. There's a lot of noise on the internet. ChatGPT is dealing with noise. All these Gen AI models are dealing with noise on the internet, and what's really out there is true information. Bringing in good OSINT, business intelligence, things like that. You're going to have to wrap a lot more information other than the claims data around in terms of fraud to find these bad actors. They're getting savvy. They're creating hit and run type companies. They've been doing that for a long time, but it's becoming easier and easier to do that. Building LLCs on the fly and things like that. So you're going to have to wrap a lot more than just the claims data intelligence around what you're looking at to really find these bad actors. And then you're going to have to do that in a way that gives you some speed and flexibility. So in terms of, you've got your provider and patient intelligence, which are not really separate because there's relationships there that you need to understand as well. And then you're going to have to think about prepay and how can I get early alerts or find these patterns and start building them back into my prepay intelligence based on what I've been seeing. And what are those signals? Some things are just absolute truths, like some of the edits that, you say this can't go with that. But there's thresholds and things that you need to start understanding, and manipulation of claims data, be it modifiers or revenue codes, something that's going to shift the dollars in the wrong direction. And it doesn't look bad initially, but you start to develop these resubmission patterns and things like that you want to dive into. So there's quite a bit, but it's all data relationship, provider and patient relationships. And then what are those patterns in resubmission that you can get to hopefully earlier in the claim submission and payment process. So to Lynn's point, payment integrity is not getting 27 claim submission life cycle. It's 1 or 2 life cycles and cut it down. If it's really a bad actor, you want to get them out of your system quickly, and you got to figure that out pretty early. And a lot of that is going to be pattern recognition and training, good training, obviously training on your real data. Because it's hard to model off of just a little bit of random, synthetic data. You gotta have some real world intelligence out there.
Great.
So,
Thank you for that insight.
Mm.
All right. Last question then is for Johnny, which is what advice would you give to any other organizations that are considering an AI implementation?
Yeah, thanks, Rena. I had to go back and rethink this one based on uh, some feedback you offered to me, and I think that for me, in the challenges that I encountered as a business owner, is you need to first obtain buy-in from your IT folks and the folks, the data governance piece, the folks that handle the data, right? We need to ensure that they're we securely transferring the data from our data vendor over to the AI platform, and that is being transmitted properly, that it adheres to NIST protocol, high trust protocols. All of this stuff is brand new to me. Okay. I can remember being on the phone with these folks. I'm like, okay, what is this? Okay, this, high trust this. And my bosses asked me, well, Johnny, what does that mean? This, high. Please, on the front end, you got to learn what the procedures are, what security protocol should be in place, because it is critical. At the end of the day, we don't want a data breach to occur, right? This is what we're trying to prevent. So we certainly want to make sure that those protocols, security protocols, are in place. Because at the end of the day, we'd hate to see someone's PAI information get compromised. I think a good working relationship with your contracts administration section is critical, right? I'm not a lawyer, but the folks that we have, Patrick Long, I wish you, man, Patrick saved me so many times. He was my direct contact when it came to us crafting the language for the statement of works with, Carosoft and Codoxo fraud scope, who is going to be responsible for what are the duties of the business owner, what are the duties of the contractor, what if something goes wrong, what procedures do we have in place, right? I think that is also critical. I think Rena and I, we sent several versions of statement of works back and forth, but we're here today.
We made it.
And then I think finally, the AI platform, just understand that every Medicaid program has its own uniqueness. In Georgia, we assigned the Medicaid ID numbers by location, right? So the flag, the Codoxo system or AI platform, it identifies the aberrant billing trends associated with the NPI. So the end user needs to understand you got to have the capability to drill down a little further to get to the specific location. I mean, God forbid, I can't drive all over. If this provider's got 6, 7 different locations, it's unreasonable to expect me or my staff to drive to 6, 7 different locations in a day. Yeah. So the end user would need to understand that the system in Georgia, at least, it may be different for another state, but in Georgia, just understand that the Medicaid IDs are assigned by location, and under the NPI, there may be several IDs or locations. I think that's all I have.
All right. Thank you. Thank you both. All right. We're going to open it up for questions. We have time for questions.
I'm intrigued by what you were talking about in terms of figuring out density per provider. Is that something you can only do if you're in the situation of Johnny, where he can see all of the data? Are there ways to use AI if you're a regional payer and you may be a small part of that provider's panel?
let's see, do you want to take that or you want me to take?
You take
I take that one. Okay. In our platform, it's at any level. It doesn't matter. I mean, we can do density per. We're looking at peer groups. So, if you're saying it's a provider that's a gastroenterologist, we're going to look at all those gastroenterologists. We don't. If you're talking regionally, are you talking about mixed plan intelligence? Or are you looking for like cross plan?
Pair.
Mm-hmm.
One provider, you need one.
Sure. Yeah.
only see the pays.
Correct.
Mm.
Yes. Yeah, absolutely. Yes, that's been the classic problem. It's that, a provider could be servicing 16 different plans and nobody legally, none of y'all can talk to one another. And you just can't. Like there's just that's a barrier. Um, we don't mix the data, but if I happen to have data for a provider across 3 different plans, I can see what's going on for sure.
So is there a call to action for
There is, yeah. We've
Mhm.
talked about benchmarking our data
Yeah.
in the future, so we'll definitely be doing that.
So what I can add, Rena, if I may, is I'm actually in the process of facilitating some conversations with our Medicaid fraud control unit, because that's a concern of mine as well. So we got 3 different plans plus fee for service. If, for example, the system says, hey, this provider is billing for more than 24 hours in a day, but you can't see it unless you look at the entire enterprise, right? So for me, that's a phone call to Mafuku to say, hey, I want you to take this as a fraud referral based on data analysis alone. The problem is if I send out correspondence to a director review for each CMO, they're only going to see their slice of the pie. They won't get the big picture. So it ends in a small overpayment, but doesn't really capture the potential fraud that may exist. It's only 24 hours in a day.
Yeah.
Well, thank you all so much.
All right. Thank you, boy.
Thank you.
Thank you, Brandon.
Yep.
You could have been.
We'll serve.
We'll certainly wait.